So just to get us a little bit started, can we just kind of go around and give a little brief introduction and like what types of research that you are using, usually enrolling subjects in your ED in? And I'll just start with my orientation with James.
Absolutely. Thanks, Susan. My name is James Paxton. I'm Director of Clinical Research, Wayne State University, Detroit Medical Center in Detroit, Michigan, and Associate Professor at Wayne State. And you asked what type of research I typically enroll for. So quite a lot of things, a lot of cardiovascular. So a lot of cardiac arrest studies that we've done. We do a lot of sickle cell research in Detroit. So that and stroke would say are the three largest areas.
Sure, I'll go next. My name is Shanna Haynes Harp. I'm the Director of Research in Emergency Medicine at Mount Sinai. We currently have sickle cell. Sickle cell is one of our biggest portfolios. Our next biggest is toxicology research. We have a mix of clinical trials and then PI-initiated grant-funded studies. We have a lot of HIV, STD because of our location. We do a lot of studies with and research with immigrants, sex trafficking victims. We do a lot of research in the prisons. And then I think our smaller portfolios would be more health services research. And then we have like health equity research.
Great variety. Okay, how about Josh?
So my name is Josh Davis. I'm an emergency medicine physician in Wichita, Kansas. I practice at largely a community site for a private group. I also teach medical students and residents at some of our local med schools. The reason I'm actually in the community, despite my interest in research, is because I'm quite the eclectic, quintessential emergency medicine who has a little bit of ADD and changes my mind about what I want to research every other week. So it's a little bit all over the place. And I was told in academics I had to find a niche, and I couldn't commit to one. So because I have commitment issues, though, I do a little bit of what some of the other people have talked about as far as cardiovascular, stroke, sepsis. My biggest one that I'm hoping to learn from today, I'm struggling a little bit with I'm doing a study on the cannabinoid hyperemesis, and enrolling that population has been a little bit difficult. So I'm hoping to maybe learn a little bit of insight there. And then my other big experience is actually prior to med school, I actually worked with PCARN and a couple of the other pediatric emergency groups as a research assistant and research coordinator, actually kind of enrolling people, and have a fair amount of experience for several years kind of doing that as well. So.
Hello, I'm Alyssa Perkins. I am the Vice Chair of Research at Boston Medical Center. And so we're a safety net hospital. So I think we have a lot of issues very specifically related to consenting and enrolling patients in safety net institutions. And then my own research is on building and evaluating public health programs, particularly infectious disease screening programs, but also have experience in enrolling patients for various randomized control trials, diagnostic assay studies, therapeutic trials, questionnaire studies. I've tried and experienced challenges in enrolling patients in all sorts of studies in the emergency department.
And I guess I didn't really introduce myself. I'm Susan Wojcik. I'm the Director of Research for the Department of Emergency Medicine at SUNY Upstate Medical University in Syracuse, New York. And I'm going to sort of host as your moderator. And I have a few questions to ask, but certainly if anybody is watching and has other questions that they would like me to get to, I can circumvent some of mine for what you guys are interested in, and I'll keep an eye on the chat while everybody else is answering, and I will try to catch those and sprinkle those in as well. And my first question is, what have you found to be the best way to staff for enrollment success in your ED? So who do you use? Do you pay them? Do they volunteer? How do you deal with scheduling? Any of those kinds of topics are fair game. So why don't we kind of go in reverse order this time, and we'll start with Alyssa.
So the way we primarily have found the most success is having dedicated research assistants. One thing that we found is that it's really, really hard to try to work clinically and then also do absolutely anything. In the past, we've tried having dedicated residents who are interested in projects do the enrollment while they are on shift. And it's really hard. Nobody seems to have bandwidth to do anything. So we, as much as we can, take that burden off of the people that are working clinically. And we have dedicated research assistants that are part funded by the department, part funded by grants. And we generally use them to do the bulk of our enrollment.
Yeah, so I'll take the next one. So to actually answer your question, which is how do you staff for enrollment success, it would be 2 full-time research assistants and a research coordinator at all times, 24/7, all of whom are paid a living wage and able to do that. That's not realistic in anything I've experienced anywhere. I actually have quite the opposite here, which is I don't have really any research support. We have like an institutional research coordinator, but we don't even have one for our department. So that leaves me and like getting creative with like our scribes and undergraduate students and things like that. Some of whom get some pay at some times, but most of which is volunteer. And you deal with the repercussions of that, not paying people, you get the quality that you pay for. Lots of these people are interested and they want to do good, but there's only so many hours that people can do of kind of volunteer and unpaid stuff, particularly when we're talking about like, long-term studies. I mean, I think many of us have had like, the med student for the summer for 6 weeks, which is just like, in my opinion, it's just like not helpful and not enough like research exposure to get anything kind of done in that time frame. I will say in terms of getting into a little bit more nitty gritty about what you're talking about, I think it is a little bit study specific, but in general, in the emergency department, you really need someone in that like midnight or 2 p.m. to like midnight time frame for the majority of studies to hit the majority of your population. If you have someone who's there like 6 to 3 or 9 to 5, you really miss out on a lot of the volume that you're looking for clinical studies. That being said, if you're doing something, for example, like Shayna was talking about, like, when you're dealing with social aspects and things, actually get a different population between like midnight and 5 a.m. And it actually is important to capture that population. Whereas if you're doing an interventional study on, an MI, like what time they come in probably doesn't play a big role in that. But like whether you have social work or whether the shelters are open or you can, have, refer someone to call their primary care, like those actually play a role in some of those. And it's important to consider that in terms of success too.
Yeah, I think I'm next. We do have dedicated clinical research coordinators, and then we have dedicated study coordinators. I don't know how much I should get into this, but we had a shared pool model for a while so that senior staff would have their own dedicated clinical research staff or study staff. And the junior faculty who don't have the major grants or the money that senior faculty would have could use portions of those CRCs and study coordinators to help with their enrollment and help with the aspects of their own research. We found that if you don't have anyone, it's just difficult to get it done. So the junior faculty can benefit from the senior faculty using the shared pool model where we have about 10 study coordinators or clinical research coordinators, and then they get a certain percent of each one to help carry out their enrollment goals for their studies. I'll just leave it at that. It gets a little bit more complicated, but we have dedicated staff.
It's really interesting. That's the first time I've heard of a model like that. So thank you for sharing. James?
Yeah, that's great. I mean, obviously, being in an urban center, probably similar to a lot of what we've already heard. But I think one thing that works well for us is, of course, we have a nucleus of people who are paid, as Josh says, a living wage to do research. And so those people are, going to be working usually days, but oftentimes swing shifts. We try to have at least one of those people on during high traffic hours. We have the advantage of having multiple clinical sites. So we enroll at Detroit Receiving, but also at Sinai Grace. So we can kind of cross cover each other, which is a huge benefit if you're able to do that. And so that kind of speaks to collaboration, possibly with either other departments or other institutions. If you can find ways to cover multiple sites, that's super helpful. But you do have to have some people that are paid in order to do it right, because, unfortunately, people do what they're paid to do. As far as volunteers go, we found a lot of success with pre-professional people. So not as much with the med students. I mean, med students are great, but, they have very limited availability and bandwidth. But people who are looking to get into medical school, people who are looking to get into nursing school, pharmacy school, whatever, who have maybe already got their bachelor's degree, but they haven't yet gotten into the grad school, are a huge asset to the program. We've had people who joined in thinking they're going to do a 6-month stint, been here for 5 years, loving it. And it's a great reason to take a pause on your professional journey, and you learn a lot. And especially if you're interested in doing emergency medicine or research, it's a great opportunity, and you can get a great letter out of it. So I think, on average, perhaps the volunteer model is not great, but in that instance, I think having pre-professional individuals is a huge deviation from the norm for volunteers. And we do try to incentivize people as much as we can. I think it's good to have a good mix. Yeah, we really don't bring med students into the department for enrollment purposes. We've tried it. It doesn't work out very well usually. When we do bring people who are volunteers in, we are very clear upfront that this is a requirement of X number of hours per week, and we make them stick to that. We have a person who's in charge of that and watching that. And so the number might be 10 or 20 hours a week, and people know up front if they can handle that or not. So we do have some attrition with that, but I think that's an important distinction to make, that you set those goals and boundaries up front so there's no confusion later on about how much you're expecting folks to do. We're not being paid to work.
Now, how do you market for those volunteer individuals? Do you just have something on your website? Do you have a volunteer office that coordinates on that? Do you go to colleges and universities? How do you publicize for those positions?
Well, I can start the response on that. It's all the above, right? So we have a person who's me in the department who is kind of the funnel through which all these queries come. And I usually have a 10-minute conversation with anyone who's interested. And if they sound, legit, then I'll forward them on to my team. But we have to have somebody to vet those. Otherwise, people will be inundated. But I mean, I have full disclosure. I'm affiliated with Wayne State, which is the largest single campus med school in the country. So, I mean, we have no shortage of people who are around. But I think the best way that we find people sometimes is reaching out to people who know people, and I think we sometimes miss that in life, that we don't think of who we might have connections to 2-3 degrees of separation. Maybe someone's kid, one of your colleagues might have a child that's 25 and wants to do something to promote their professional career, et cetera. So I think asking around is helpful, but also having a pre-designated way of screening those individuals when they do come around, and, not inundating your research team with a bunch of requests that might not pan out to be anything useful.
I'll just add one other thing that we do for our kind of volunteer group. So you mentioned letters of recommendation and then offering publications. I think people, who put in a considerable amount of effort should be listed on a publication. I think that really helps jolt their career. The other thing that we do is we actually do a mock interview for people who are interested in going to professional school. So we'll take me and 2 of the other medical directors, or 3 or the other medical directors, and they'll actually do like their med school interview, like as a practice for them, and give them kind of feedback on that. And I think that also goes over really well. Basically aligning that, like, this is something that's setting you up to kind of move forward. And we're not trying to hostage you here, and we actually want you to be successful, even though we don't want people to like leave and it's a lot of turnover. That is really what our goal is for people. I mean, I think that word of mouth actually gets out, like, among the school and stuff, like, because we have a local undergrad school. And like, I think that gets out that like, hey, like so-and-so got into med school and did this program. And, I think like something like 80% of our people who are trying to get into a professional school, like, actually get accepted and stuff. And so that, I think, gets out too. It gives them something that's not monetary compensation, but is a compensation in some way.
We have volunteers as well. We do go into the local colleges and advertise that way. We have a relationship with a few of them around in New York City. And so we do advertise, and we do get flooded with a lot of people who want to volunteer. And of course, we have to vet that because we do want certain caliber of people to come in. We do not include them, though, in enrolling patients. There's way too much regulatory hurdles that we have to jump over, but they're useful for red cap design. They're useful for other aspects of the enrollment process, just not talking to the patients and consenting.
Yeah, we have volunteers in a very limited capacity, and we use them as Shanna does. We have not had a lot of success having them actually in the emergency department enrolling patients. We have them doing data, like database data abstraction, red cap design, things like that. But we really have not used a model that James or Josh described. It hasn't been successful for us at all.
The other thing I would add, Susan, is, the question was about enrollment in general, and I think scheduling is important. One of the things that I realized early on with enrolling for studies is you want to look at where your high yield is. And it was mentioned you want to tailor your approach to your study. And I think that's 100% true, because if you're doing a trauma study, it is very different, as Josh mentioned, from a cardiac arrest study in terms of when you're expecting those peaks to come in. And looking at, if possible, to look at the data from your institution to see when the highest frequency of cases comes in for whatever condition you're trying to study, assuming you don't have 50 studies going on, that is. It could be incredibly helpful in terms of not missing as many patients, increasing your yield.
Yeah, I think that brings up 2 really good questions for me. One, I guess, in trying to maximize the timing of the scheduling for the enrollment, what do you set like a success capture rate of, like, what percentage? Like, if you look and see, we typically see this many a month, like, do you have an expectation of what you can capture for research and get them enrolled in a specific study, or do you not even go there?
So I can answer this. Our expectation is that we will capture a very, very small percentage of them. We have real hard time with enrollment in general. I can put it in the chat. We just published a paper about some of our challenges trying to enroll for a COVID study that we were doing. And our expectation is that under 10% of any given, class of patients will actually successfully be enrolled from start to study completion for those longer studies that require, multiple follow-up visits or phone calls. Our success rate is poor. We just expect that.
Yeah, I hope people do an approach rate, like the amount of people who they approached who were eligible, like during the time when they were there. Like you can't enroll someone or approach them if it's like they don't show up at a time when you're not supposed to be there. But I do think, holding people to at least approach people. I find a little bit of an ethical issue with trying to like encourage people to complete the enrollment. I feel like that puts a little bit of unjust, maybe pressure on people. If they somehow get compensated or rewarded for completing the enrollment, they might feel the need to skirt consent process or something like that, which I really don't want to happen. And also in the long run, doesn't help you. All of us have had people that consent initially and then you never hear from again, or actually just tell you that they didn't actually want to kind of afterwards. And that is just a waste of time and resources to go through all of that enrollment and put them on a log and all that, to collect all their data just for them to kind of drop out the next day or in a couple hours. But I do I think holding people to the amount of people they approach, I think is the best that I've found to be successful.
I like that approach. That's different. Anybody else have any suggestions or ideas on that?
I will say, like, some things that we've done because of the timing, as I think we've all sort of alluded to, the timing doesn't always line up as to when your research assistants are in the department and the patients are coming in, is that we've utilized IT to flag, patients who meet whatever given criteria. If they are in overnight or on the weekend when our research assistants are not there, there is an epic flag that, or like a chat. It goes to, I don't remember how IT set it up, but there's like basically a chat that goes to the research assistant so that when they do come in, they have, they can see the patients that they missed. So in addition to sort of scrolling through the board for who's there, they do have information for patients who are no longer there. But then they, depending on what the study is, they can call them after hours if that's appropriate for the study, or they can add them to sort of the list of patients to be on the lookout for, because we have so many, we have a lot of repeat ED visitors. And so it sort of lets them know who's passed sort of the basic screening criteria for a study, and then they can look out for them if they do come back to the emergency department.
Flexible hours is another thing too, right? So you can encourage people that if your time is 2 to 10 and somebody walks in at 9:59, I actually would rather you go approach and get the consent done and just come in an hour later tomorrow when nobody's there. And I remember, like I mentioned, I did a lot of kind of pediatric emergency work. I remember being there like till 3 or 4 in the morning some nights doing bronchiolitis during bronchiolitis season and things like that. But I was given the encouragement from my group of that's fine. Like, we're not holding you to these stringent 2 to 10. And if I had to go, I had to go. They wouldn't hold it against me. But if you want to stay because you're enrolling 5 people who just came in at between 9 and 10 o'clock, that's more high value than you meeting some arbitrary kind of time cutoff.
We try to be flexible with our staff. We don't have anyone doing overnight only because they need supervision and we can't provide that. But we do have late hours and we do have weekend coverage. So that helps us trying to capture as many patients as we can.
And I think the other thing James mentioned, he said, well, if you have 50 studies. So I guess my question is, do you guys have a limit on how many prospective studies you try to manage in your ED environment at any one time? Do you ever say we're going to hold off on a new study till we complete something? Or is it feast or famine? You just roll with what you got when you got it? How do you guys deal with that?
I think at my shop, we try to find things that fit into what we're maybe already doing or already familiar with. If possible, that's maybe like our first choice. If it's an extremely compelling protocol where we think we can enroll gangbusters and it's a light lift, then absolutely we will consider it. But we have an advantage in this way that we have a couple people who are very senior in our department among the research team. Our research administrator, been with us for 15 years, 20 years, and a research nurse who's been here for 10, 15 years. And these two people honestly do a lot of the vetting. If I get a protocol, I'll go over it to these two people and say, what do you guys think? Does this sound feasible to you? I'll get their feedback. And then if necessary, take it to other people in the department. But I think it's having people who have their finger on the pulse. If that's not you, find out who that is. Make sure that person's involved in screening new protocols, making sure that we're not exceeding our bandwidth, that we have adequate staff on hand, that it fits well enough within your current, list of studies, that it's not going to be too much of a stretch, because nobody wants to stretch too far out of their comfort zone unless it's a really compelling protocol. So I think it's really the key here is maybe not having a number of studies or something, but having like a limit in terms of just a gestalt of what is our bandwidth, what is our current, process, what are we doing right now, how much more can we really accommodate at this time, and then thinking forward in the future about, okay, well, in 9 months, what are we going to be enrolling for? Which studies are going to be done? When is this new study going to start? Is it going to be a year from now, which a lot of them are, right? So is that okay? We can go ahead and pursue it while we're, tapering off on something else.
Yeah, I would agree with that as well. We don't necessarily, I don't think we have a number. We try to be aligned in whatever we decide that we're going to be, whatever studies we're going to be running. And we usually use, this may get into a different question, but we usually use, our research division meetings or different types of faculty meetings to present what, especially if it's a clinical trial, what we're considering, and then have everybody weigh in. Yes, it's feasible. No, it's not feasible. It's competing with something else. It's not, all of this. And that's usually how we decide what we're going to bring on. But a number actually might be something we should consider.
So I'm all for like the economies of scale, right? Like, so if you're going to have a research assistant and you have 2 studies, like the third one is a great idea to bring on, right? Because then you have someone there during that time. And if it fits to do it, that's great. I think, I'm not at the place of having the luxury or the burden of having, 50 or whatever studies going on like James does. I have me. And so my number is my bandwidth of what I'm willing and able to do, which unfortunately I've been historically very bad at estimating, and saying the word no to people is historically very difficult for me. So I think I probably err on the side of stretching it a little too thin, and honestly at the sacrifice of probably some quality, to be honest.
Yeah, I think for us, the consideration is first, what is there salary support for a research assistant with a given study? And if the study that we're considering has salary support, is it sort of commensurate with what we think we'll be able to do the work for? And are we able to, what is our sort of FTE breakdown? Are we able to take on 50% of another RA, or can we, shift some of the work that a particular RA is already doing toward this study? For unfunded studies or ones that don't come with, salary support for a research assistant, we have a couple criteria that we look at. The first is, does it fit with the mission of our department and, the things that we want to be studying? Is it aligned with a particular faculty member's area of interest? And then we do, particularly for residents or fellows, when they are, have a passion project that doesn't necessarily have funding associated with it, we do try to figure out kind of where is, are we able to pull some resources for these particular studies? We do that a little bit less so for faculty.
Another thing, Susan, to bring up here is the importance of inclusion and exclusion criteria, because on the surface, a study might seem to conflict with another study. But what I found frequently, especially when you're in, let's say, a subject area, I'm going to use, for example, sickle cell. What's an inclusion for one study might be an exclusion for another, and so forth, vice versa. And so it is actually quite, and Josh mentioned economies of scale. I think it's important to recognize that, if you have, let's say, 3 studies in the same area going forward, you might actually get you might be able to catch one for one study that wouldn't have been eligible for the other one. So it could be an advantage to have, 2, 3, 4 studies for the same medical condition, depending specifically on the inclusion and exclusion criteria, which sometimes, when you get approached about a study, they don't always include that in the abstract of the protocol. They'll say, oh, well, we don't study about anticoagulants, but I want to know exactly who you're trying to get in the study and who you're not, because that's more helpful for me than knowing, what medical condition or what drug you're studying.
Great. Those are all great points. Thank you. I want to switch a little bit to sort of the nitty gritty details of getting research done in the ED, and then also sort of like more along the lines of, are there things that you've done that have actually helped you improve your enrollment in the ED? And I was wondering if anybody has any sort of procedures for enrollment that they have found that if they do things a certain way, or have found sort of the success button there for really kicking off your studies and that process of enrollment and being more successful. tips or tricks? Anything that anybody wants to give up?
So I'll give a couple. I think one that was already mentioned was like bringing it up to your faculty beforehand and discussing and identifying those areas up front, right? Like if all your faculty's like, no, we're not doing this, then it's not worth putting your time and effort into something when you have other alternatives that might be more successful. I think you have to design for success up front and consider that when you're doing this. The enrollment process is actually equally as important, if not more important, than some of the like interventional nature, and the blinding and the placebo and how that's made in the pharmacy or whatever other thing you're thinking of. Like actually, if you don't enroll the patients, then it's not, you're not really doing a lot of value. And so some of the things that have been helpful, we have signage sometimes that helps remind people. We have, when we have like our shift huddles, we sometimes go out and kind of talk about the different kind of, at least one of the studies for 2 minutes, right? Like you don't take up a whole lot of time. You just kind of remind people that it's going on. So when they see people, they are familiar with it. I think you need to make sure that you have like things that are easy. So you can't rely on clinicians to enroll or notify you of eligible patients. You have to have some other way of doing that, whether that's an EMR, if you're blessed with an IT group that can do that for you. I know all the EMRs can do it. It's just whether somebody is like willing and able to set it up for you, or having someone like doing like a research assistant kind of doing a screening of the tracking board and whatnot. And then making sure that like your consent area is like you have it set up, like you have packets that are together that have all of the papers that you need, like in one place that's easily available in the emergency department or in several places in the emergency department. So it's like readily available. And those are things that they're like little things that you don't necessarily think about when you're starting a new study that actually are like really crucial for success, is like put all of the papers that you need in one like folder for each patient so that you can like keep track of them and then kind of follow that kind of type stuff. So those are some of the things. And then I think when you're doing the actual consent is making sure that patients, again, understand what the potential kind of benefits to them are. I think people are more likely to, if you can explain that in a manner that, like I said, is appropriate. I don't like coercing people into things. And I don't look at people not consenting as a failure most of the time. Sometimes I feel a little bit of a failure when people don't consent, when I feel like they really didn't understand what I was trying to explain to them. But the majority of the time, I think that people understand and like choose to say no. And I don't view that as a failure. I think that that's kind of someone's autonomy. I do struggle, particularly in emergency medicine, as I was mentioning, with this kind of cannabinoid hyperemesis, with like people who won't even speak to you kind of type stuff. And it's not really to the level of needing an EFIC or an exception from informed consent, because they're not really that critical. But I find that to be a little bit difficult. And I imagine maybe Shanna has some stuff from some of her kind of, sounds like you do a lot of like social and underserved kind of issues. And I imagine you maybe run into that sometimes too. And I could imagine, trying to do it. We have a high methamphetamine population. I can imagine trying to consent someone on meth who's technically like has capacity, but would just be a very difficult thing to do. So those are some of the things that I struggle with too, in addition to some of the tips I have.
Yeah, I would agree with a lot that Joshua said. We have to have the buy-in of everyone. And I mean, the NPs, the PAs, the nurses, like I think the biggest mistake I've seen in the past is just relying on the study coordinators or the clinical research coordinators to enroll patients. It's just not going to work. The PI has to be involved. And I know a lot of PIs don't want to hear that, but when they agree to conduct a study, clinical trial research study, they have to be involved. They have to present it to the staff, to everyone. They have to sell it. They have to get the buy-in. The CRCs are great and they're extremely helpful, and we couldn't get anything done without them, but nobody is going to really listen to them as far as helping with identifying these patients and looking for these patients and keeping it on the forefront of their brains in a crazy ED. I also think just a couple logistic things, keeping the consent package clear. A lot of these clinical trials, you have to move, for what we're doing, we have to move from the ED to go take imaging, to go making sure the workflow is at least complicated as possible. The more that the patients have to move, the more they're turned off from the study, especially depending on what they're there for. And then really having, I think, a couple of mock consenting, especially like Joshua mentioned, for certain demographics. There has to be a way to talk to them, to present the study to them. And then one more logistics, our study coordinators, I don't know if anyone else has this issue, clinical research coordinators don't necessarily stay in the ED. They have to keep coming over. So we've gotten rolling carts so that they can stay in the ED and, move within the ED and not have to lose time coming back and forth. So those just have been a couple things that have helped us.
I can go next. I think a couple things on the sort of staff level barriers that has been addressed. I think, as we've said, like it's super important to have buy-in from everybody. One thing that we found that's been really successful is giving feedback on enrollment. Like, hey, we're doing really well. Like, this week we've enrolled this many patients. Sometimes for a couple of studies, like we've actually kind of gamified it and like said, oh, like, who's the person who's enrolled the most number of patients in studies, things like that. So just giving, but even just general feedback, like, this, here's some successes that we've been having with enrollment is really helpful. At the level in our hospital, we have a lot of patient level barriers to enrollment, particularly language has been a really, really big one for us. And we would not have any success at all if we were only enrolling in English. So we routinely provide materials in our top 6 languages, and we go through the trouble of translating consent forms into our top 6 languages and really making sure that we're able to enroll patients in multiple different languages, because that's been a huge area for us. We just have so many non-English speaking patients. And if we were to, we try to hire multilingual research assistants when possible. But even if we can't, we have translator services available as long as we have the consent forms translated into those languages.
Well, some really great ideas already, but I throw a couple more things out there. So one thing that's helpful for us is certainly screening using Cerner, looking at chief complaints, looking at charts. There's a HIPAA waiver there. So that's, I think, extremely helpful to be doing that when people aren't actively consenting, enrolling people, that they're spending time looking through charts, trying to screening for patients, really. We talked before about volunteers versus paid staff. I think screening is certainly something that volunteers can be helpful with, which is, not patient facing, but certainly still helpful in terms of identifying potential enrollments. I heard mention about the unfortunate situation of not having a research office in the ED, but I think if it's possible to have a space that's designated for your research team, that's physically in the emergency department, even if it's just a shelf somewhere, that would be immensely helpful to most people. We have a small office in the department that's right next to the recess bays. And so it takes literally 10 seconds to go from the office to the recess bay. And so there's really no reason that our team can't be right there in the department at any time. Screening logs are super helpful for us. So we even when it's not required by the sponsor, we try to do screening logs, because not only does that prove that the person did the work, but it also identifies problems and patterns. So when you look over the screening log and you see one screen patient for a shift, you say, I only one patient, and people at least have to, describe their trouble or their barrier. And in some cases, we found things that are actually useful to us to improve the process by looking at screening logs and saying, where did we fall down on Wednesday? What could we have done better? And maybe it was just the lack of eligible patients, or maybe it was we were distracted by other things. And so there's ways to streamline the process by doing that. It was mentioned that it's important to have the PI involved. I absolutely agree with that. And selfishly, I can say, if you work in a department with 10 other PIs, and you're the one that's always down and showing face, and you're the one that's always answering emails, and you're the one that's shaking hands and smiling, guess whose study's going to get more enrollments? It's going to be the one that people are, feel is doing a good job and involved. So as a director, I want to see all my research faculty doing those things. But, as an individual investigator, I'm going to do those things because it's going to help my study, hopefully, at least as much as it helps others. And then the last thing I would say is recognition for a job well done. And, when you have an enrollment, I think one thing we do well is recognizing the enrollment happened. Then email goes out to the faculty listserv. Hey, we enrolled a patient in study X. And then importantly, someone from the faculty will respond all back and say, great job. Thank you for the enrollment. We appreciate your time. Way to go. And that's in front of the entire faculty every time we make an enrollment. And I think that can be helpful for some people. Not everybody cares, but some people are motivated by that.
And I think another thing too, just to add on to that one, is recognition and, if possible, kind of incentives, as we're talking about in the chat, for your clinical staff, like your nurses, right? Like so-and-so triage nurse called the research coordinator and identified this patient in triage. And, we really appreciate that. Or, here's your $5 Starbucks gift card, or whatever other thing that you can kind of do to incentivize that. And then the other thing, going along with what James and a couple of the people were saying about getting the PI involved, I actually think, again, as a team of largely one that I have here most of the time, I do think that having the PI actually do the first couple in like 1 or 2 enrollments is pretty helpful. It shows your effort and engagement, and doing it sporadically thereafter as well, being willing to, when there is a potential patient, do it yourself. But also it helps you as the PI have a little bit of a grasp on what it takes and where the barriers might be, and like, you know, why it's like, sometimes your research assistant or coordinator or volunteer isn't going to tell you that it's absolutely, or isn't going to recognize like how much of a headache it is to walk all the way back to the office and walk back. They just think that's the way it's done and that's the way it's supposed to be done. And like when you do it once and you realize you have to do that, then sometimes you're like, oh, this is not, great. And there's a better kind of workflow we can do.
Yeah, and Josh mentioned the chat a little bit, just in case people aren't following that. Someone did ask the question about whether or not we had any advice about getting patients to continue in the study, sort of like, and reducing your loss to follow-up. And Josh provided a couple of suggestions about increasing incentives as they go through the follow-up process. So more money as they get further in as far as a gift card goes, enrolling only patients that are committed to following up, and then also making sure that they have phones or transportation or whatever is really necessary for them to follow up. And then Shayna mentioned, and this is something we do here quite a bit, is reaching out in between visits. So making sure that you are keeping that constant contact with all of them. I don't know if anybody else has any other suggestions on that type of a question line.
Yeah, one thing that I would add to that is because, like, I think this is very probably specific to the safety net population that we have, but we are very aware of the barriers that our patients have toward coming back for their follow-up visits. And when we are talking with sponsors, we usually add in transportation vouchers to our budget. We, like in the past, like when we were dealing with laboratory specimens, we've actually paid for courier services to come pick them up rather than having them drop them off. Like just being cognizant of the barriers that our patients face to these multiple visits and trying as much as we can to mitigate them. I think that's one thing that we haven't really talked about, but I think there is a role of the study sponsor in sort of providing some of these things, especially if you're looking at, trying to get patients that are not historically represented in research into research studies. It involves a commitment of the institution, but also the study sponsor to really provide some of these additional support and financial supports in order to get those patients enrolled. I think that's sort of a problem in research in general. And I think that that's one way to try to mitigate it, is to really do your best to recognize what barriers our patients have and try to support them through those barriers.
Okay, great. So some of the other things that came out of the last couple of questions too is, specifically not just the PIs, but sort of like you had a lot of suggestions of things that would be helpful for enrollment for the PIs to do. But are there other things or even things that the PI can do sort of to increase the support of their colleagues, or just in general ways that you've dealt with sort of other physician or staff resistance to research happening in the ED? I'm sure everybody doesn't want to play, right?
Yeah, I mean, I'll be honest, I just bulldoze on through them. No, I mean, honest, like you're not going to convince some people, and it's not worth your time and effort to try to. It's very similar to like trying to teach point of care ultrasound to some of the white haired docs that we have in our group. Like some of them are just not going to do it, and is going to take a lot of time and effort on my part for very little gain. And I do the same thing with some research. Like you take the time, you explain it at the faculty meetings, you talk about barriers beforehand, you bring it up again, you do the thing James talking about sending out to the faculty about a good enrollment. You do kind of what I was talking about. You talk to the nursing staff at their kind of department huddles every once in a while, and kind of send out stuff through their leadership. You do those kind of type things, and then there's still going to be people who are just like hesitant or not helpful, and you just keep on moving right on through. You enroll them if you can, and if it ends up being a problem, you don't. I never had this kind of go to this level. I mean, you could, raise a concern if someone is really being a big barrier to like, the chair and stuff like that. But I've never had to take it that far. I honestly just basically ignore it and keep moving.
Yeah, I think one thing that's really important is to take it off of the RA. The RA is usually the most junior person that's walking around the emergency department at any given time. And if they've got, if there's a person who just is never going to enroll a patient into the study, like the RA takes it very personally. I'm sure it contributes to like a lot of RA sort of feelings of inadequacy and burnout and frustration. And so I let my RAs know, like, just come to me if there's problems. Don't try to take this on yourself. This is something that I can help with. And then I usually have a conversation with the people, but like really try to not put that burden on the research assistants, because they're not going to be successful. Like they're just not, and they're going to internalize it and it can go very poorly for them.
I would say I can't say that we have resistance to the research. It's just, to me, I think it's mostly just people not remembering. It's just, and I understand it. So I think it's been said several times, just keep bringing it to the forefront of their mind. Every Monday, reminding them, or, how often you need to remind the other doctors and the other staff about the research. We even had just like brief little laminated cards with just like maybe 5 inclusion criteria or maybe 5 exclusions, just so they could keep in their pocket, pull it out real quick, try to make it as easy for them to remember as possible. I think that's what works for us.
Yeah, I think all those are great ideas. And the other thing I would say is, and it's been said, but some people are just lost causes. Some people do not see the value in research. Even in an academic department, there's going to be people that will just not be willing to do anything to support research. And that's just the reality. I think when that happens, it's fine. If it's excessive or it's obtrusive and obstructive, then yeah, you could go above them. But at the end of the day, you're probably just going to bypass them. And as Josh says, bulldoze through them. So I think at the end of the day, recognize the lost causes, but be available, as others have said, to, discuss things with faculty. If the Dr. X has a question about the study, please let them call me. Here's my phone number. They can call me whenever they like. And then maybe even having side conversations with those people after the event to just discover what it is about the study they didn't like. Is there something I can do to explain the situation or improve the next time someone comes enrollment? Is there something that we can do differently? But realistically, there are always going to be people that are not going to support the mission, and you just kind of have to work around them.
Are there any tools or resources that you have used that improved your enrollment success or like just decreased your missed opportunities to enroll? Like, are there certain software packages or processes or different things like that you guys have employed or have found have been very helpful to improving your enrollment success? We already talked about sort of having a screening log, different things like that, but are there other management tools or other things that have, I think someone also sort of mentioned the chats, the Epic chats, any other things along those lines that have really...
Some of the EMRs have the ability to, from a registration perspective, if somebody registers with a certain complaint, some EMRs have the ability to trigger like a page or a message email. So if somebody comes in with chest pain as a chief complaint, then the system just automatically generates an email, says patient has been triaged with chest pain complaint. Whether those are possible at your site may depend on the individual and the IT support, but I know that's an option, and we've looked into it at our department. It hasn't always worked out, but something that may be available for some people.
Yeah, for us, it's like a lot of the challenges are on the callback and the follow-up visit side, and really honing down a system to keep track of, who we've called, how many times, whether it's using, you could do it in RedCap, you could do it in Salesforce. I'm sure you could probably design a way to do it in Excel, but like whatever mechanism you're using, having your team be, especially if you've got multiple members, really filling out that follow-up log to make sure that you're not missing opportunities to contact people for follow-up. And, I think that's one thing that we've gotten much better at through the years.
Just logistically, this may be very elementary, but just the communication between the CRCs and the research coordinators we use Teams, where everyone's on like a group chat. Hey, I found someone. Can you remind me again, about this or that? It just kind of decreases the amount of time we're waiting to send an email or you're waiting to call Dr. So-and-so. And then, and then you lose the patient's interest. So just keeping up with the communication on Teams helps the whole team to be involved and to try to, recruit as many patients and decrease the amount of lag time where we may lose someone.
All right, so we're just at about 2:50, and I had said initially to my wonderful panelists that I wouldn't keep them much longer than 50 minutes. But just in parting, is there anything else that when you wanted to be on this panel that you thought you wanted to tell everybody contributed to your success in increasing enrollment that we haven't already covered with my other questions? I'll give you guys the last words.
Well, I'll just say, take this as an opportunity today to go thank your research assistants and volunteers and coordinators and tell them how valued they are, and maybe take them out to lunch or something nice for them, because they're really the backbone that makes all of this kind of thing run. Without them, you don't really get patients, and without patients, you don't really have the studies.
I'll say this stuff is really hard. It seems like it shouldn't be as hard as it is, but the environment in which we work is chaotic. It's, stressful. It's very fast paced. Like it's really hard to enroll patients in an emergency department, and just celebrating your successes where you can find them is really important, because if this were easy, then everybody would do it. Or maybe they wouldn't, but maybe they would.
I was just going to say a couple things. I think the key thing for me is that research is about relationships. I think that if you want to do research, it's about people. It's about people, or patients are people, subjects are people, people enrolling people are people. So everyone's a person. And I think recognizing that the people involved matter, going to your ED staff early when you have a study in mind and explaining it to them and getting buy-in and getting support, but more importantly, listening to their issues and concerns is a huge part, not just planning the study, but executing it. I think having people in the department who are champions for your research is important. So it's not just you or maybe your paid research team that's advocating, but maybe a couple nurses that just love this study and really want to drum up support. Getting out there and explaining it to people and getting these champions trained and aware of your study. And then I think importantly, maintaining a visible presence in the department, and that's hard to do if you don't have a research office, but there may still be ways to make sure people don't forget that research is happening and that you're there and that you're available whenever they have questions, concerns, or patients to enroll. So I think, again, all about people working with people. And if you remember that, I think research gets a little easier. It's still hard, but it gets a little easier.
Great. Well, I want to thank all of the wonderful panelists. And I just want to let people know that if you are searching for advice or other colleagues to commiserate with or to get ideas from, that we are all members of the SAEM Research Directors Interest Group. So please come and join us at any point in time and meet other colleagues out there across the country that are also trying to be successful in their research enrollment. And we would be happy to have you join our group, or just reach out to any of us with other additional questions that you may have to help with your enrollment endeavors. So I just want to thank everybody and good luck enrolling. And I wish you all the best of success with your research studies. Thank you.